We're delighted to begin this program with remarks by Senator Bill Cassidy from Louisiana. I want to welcome him to being here and thank him sincerely for all he's done on this issue and continues to do in the United States Senate. He is a physician who for nearly 3 decades provided care for uninsured and underinsured patients in Louisiana's charitable hospital system. Senator Cassidy attended Louisiana State University as an undergraduate and at medical school. In 1990, he joined the LSU Medical School teaching students and residents. In 2006, he was elected to the Louisiana State Senate. In 2008, he was elected to the United States House of Representatives. He represented Louisiana's 6th Congressional District. In 2014, he was elected to the United States Senate. He serves on the Health, Education, Labor and Pensions, the Health Committee. He also serves on Energy and Natural Resources, Finance, Veterans Affairs, and Joint Economic Committees. He has a long record of service to the people of Louisiana and to this country. And we are also, I think at this time it's important to note, he has not only a prominent voice in healthcare reform in Washington, but he is a person who has worked in Congress across the lines and for Republicans and Democrats to get things done and seeking effective solutions to healthcare and to the opioid scourge. So I couldn't be more delighted to welcome Senator Cassidy here today.
Thank you, John. You sometimes have a little bit of a shock when you come in to speak. I suddenly realize that my talk is far broader than the headline. So if you say, well, this is more than what the headline of the event is, chalk it up to bad staff work. Where are you, Jeff? You're busted. We all know the problem. We wouldn't be here were it not for our common knowledge, but I'll just say a few things to set context so that we know we are all there. I go around Louisiana, but also around the country, and you just hear one heartbreaking story after another. The family of the 17-year-old who gets out of a treatment program, and the day he gets out, 2-week inpatient treatment program, the day he gets out, the pusher finds him, gives him drugs, and he dies. And the family's asking, what could they have done? Was 2 weeks adequate? All the questions that then bubble up. And unfortunately, as I say, a story such as that, we all in this room know of such a story. 63,000 people in 2016 died from a drug overdose, 21% increase from previous year, everything abating, everything increasing. So how do we address this? One thing that my staff, and we had a great meeting with John yesterday, we call it an all-of-government response, or more prosaically, I suppose, a safer families, healthier communities strategy. Now, safer families, healthy communities. What does that mean? Nice tagline, but what does it mean? And starting with my meeting with John, several other meetings that just went along with everything we've been talking about, not least of which just speaking to families back home, like the family of the 17-year-old whom I described. So some things that we have thought about, and I will again shamelessly steal from the 3 meetings I had yesterday because they were all great. But as John and I were speaking, he pointed out that CDC does not currently do epidemiological work on pain. Nor does it do real-time analysis of where the overdoses are occurring. Not just deaths, because that's an end, but say ER visits. Why is that important? I'm a gastroenterologist, and so what I'm about to describe, as you might guess, since it involves feces, is of great interest to me. If you get an outbreak of hepatitis A, oftentimes that will be a result of contaminated strawberries. And let me just trace how CDC would work when it comes to contaminated hepatitis A outbreak. All of a sudden you notice that there is a pop-up of Hep A in Portland, in Shreveport, Louisiana, in Detroit, Michigan, and in Portland, Maine. And CDC will go in and they will do typing and find out that although these areas are quite different from each other geographically, the type of the hepatitis A is common in all places. Well, why would strawberries give you and Hep A comes from fecal contamination of food, why would strawberries be giving you this footprint in different places. And they will trace it back to a shipment of strawberries from a particular field in Mexico where the worker defecated in the field, subsequently contaminated the strawberries. The strawberries are flash frozen without being cleansed. And so when you drink your daiquiri, you're drinking something a little extra. Now, that's all great work by CDC that allows them to go to that field and quarantine that field and put in new measures of sanitation by that food processor. Let's think about how we could do that with drugs. We see an outbreak of overdoses related to fentanyl scattered across the country. Someone goes in, CDC or DEA or someone, and does a fingerprint and understands that this particular fentanyl is chemically identical. Well, then how did it get there? At McAllen, Texas, Laredo, Brownsville, Los Noches, all these places along the border, they are confiscating drugs. And you might be doing a chemical fingerprint of the drugs being confiscated. And you realize that all these different places came through one place and then spread across the nation. You now know the distribution network. Well, then they have a manifest on these trucks going through. You know where they come from. And perhaps you can trace that manifest back to the field in which the poppy was grown or the chemical was brewed. And that allows DEA to come and focus their efforts. Once DEA focuses its efforts, then FinCEN, which is our Treasury Department organization which looks at trade-based money laundering, can then focus their trade-based money laundering analysis, cooperating with the government of Mexico, on this region as opposed to the entire nation. This is a way to have an all-of-government response. Not the only way. What is another way to have an all-of-government response? Again, shamelessly stealing from another conversation I've had recently with a pain physician. And she says in her practice, although Medicare does not pay for it, when an elderly person comes in with a broken hip, they will do ultrasound-guided nerve blockage, and that ultrasound-guided nerve blockage eliminates the need for opioids. They may give a little bit of fentanyl at the outset before the block is in, but once the block is in, this incredibly painful condition is adequately treated. Medicare does not pay for ultrasound-guided pain blocks. If Medicare put forward a payment policy in some situations in which they would do this, Medicare is the straw that stirs the drink. Once Medicare has a payment policy for such a procedure, typically commercial insurance will follow, then Medicaid, and it now becomes common practice to do this as opposed to giving an elderly person a bunch of opioids, which genetically a certain percentage of them are going to become addicted to. Another part of an all-of-government response, which is quite different from the law enforcement side. And the last kind of all-of-government response that I would propose is, we know, if you speak to a bunch of people treating opioid addiction, and you say, I know, intuitively, there are some which are doing it right, doing everything, and having better results. And there are others that are just mills rolling people through, collecting the check from the payor, but not getting the kind of results that the good programs have. Those providers just start nodding their head yes. I just saw Dr. Scranton nod his head yes. This is commonly known. Well, there are programs which monitor outcomes. It could be something simple. What is the rate, if somebody's on Medicaid, what is, if you track who goes through a treatment program and then shows up in an emergency room within 3 months with an overdose and trace it back to the treatment program, most likely you're going to stratify. They all will have some that have recidivism, but some will have much higher rates of recidivism. There should be a feedback mechanism where this information is given back to those which are certifying. Those programs not doing well are evaluated, hopefully increase their quality, but if they're not, they are no longer allowed to receive payments. And those who are doing it well in some way perhaps receive more payments. Again, an all-of-government response using the data analysis to give us a better response. I can go on, but that is somewhat of the meat on the bones of what we call a Safer Families, Healthier Communities strategy. Now, in my office, we've done a number of things. Just to mention, Congress and the Senate has done a number of things. The CARE Act, 21st Century Cures, allowing EMS to administer life-saving drugs, appropriating close to $4 billion to fight the crisis. We've asked GAO for reports of the Foreign Narcotics Kingpin Act, asking DEA questions regarding scheduling of fentanyl, asking Department of Education to promulgate anti-opioid addiction education information for primary and secondary school. But the issue is, what do we do next? And I think that we have everything we just described and more. One more thing I will mention, because I ran into Mr. Martinez on the way in, who does trade policy. I don't see somewhere out there, I can't see. One other thing that we are looking at is trade-based money laundering. Trade-based money laundering, cartels, not just drug cartels, but also organizations like Hezbollah, move over $100 billion a year out of the U.S. into other countries, typically through trade-based money laundering. They will misinvoice, and through that misinvoicing, allow the transfer of a large amount of money for a relatively small amount of goods and get their dollars out. Now, that's not supply, that's not demand, that's not treatment, that is financing. And if we can scrunch financing, that is the ability to just disrupt the entire process. Of that 110 billion estimated to move annually, currently the federal government claims about 7 billion of it. So less than 5% we're getting of the 110 billion that they are moving. We can do better. I'm told after 9/11, all of government response to the way that terrorism was being financed resulted in a disruption of that financing network. I think we now need to have that same sort of all of government response to the financing of the drug trade. Not that good people aren't doing good work, but bottom line, they're moving an estimated 110 billion a year, and we're confiscating less than 5%. So however good the work, there's more good work to be done. Let me pause here and take any questions. I just appreciate the opportunity to be here, John, and would appreciate any question you have. It can be about anything you wish, including LSU football, but perhaps more appropriately about opioids. Yes, sir.
Urge people to wait till you get a microphone, ask a question. Want to make comments? Do that later in the program, or
And identify yourself, please.
Hi, Senator. My name is Jackson Richmond, and my question is, you and Senator Graham tried to propose a bill to repeal and replace Obamacare. Were the GOP, as projected, to get more seats in the Senate and maintain its House majority, would you and Senator Graham reintroduce Graham Cassidy? And if so, would it include a measure to combat the crisis?
So we did introduce. The current system is not sustainable. This is not a conversation for that, but it's easily seen by a lot of statistics. On the other hand, you probably will need 60 votes. And so far, despite the fact that premiums have increased by 400%, there's been a lack of 60 votes to do something about that dramatic premium increase. So I think the lesson we've learned is that it must be bipartisan. I had previously introduced legislation designed to be bipartisan with Susan Collins, but again, got no takers. Right now, this issue is so politicized, even solutions that allow both sides to win, and that was clearly Cassidy Collins, are kind of falling on deaf ears, kind of a casualty of the current environment. Anyone else? Yes, ma'am.
Linda Galfy. I was at a bipartisan policy center meeting this morning, and a young man stood up asking a question. If people knew that Florida doesn't license any of their opioid recovery operators, so it's maybe a problem that some of those people don't know what they're doing.
I totally agree. Now, I can't comment specifically on Florida, but as I mentioned, intuitively you know that there's some that do it well and some that do it less well. And so ideally, we use the data that we have on payments. And there is a system whereby the states are supposed to report their Medicaid data to the federal government called TMSIS. We're trying to strengthen that. Although I had another organization that came in that said on the private sector as a claims processor, they have the same information. Might be a way to get there sooner. But we need to do a post-treatment evaluation of those who go through treatment. There's an old public health maxim, that which is measured is addressed. If we measure the success of these programs, we will address those that are less successful and reward those that are more. It is, in a sense, value-based purchasing. It is what we absolutely should be doing. Yes, ma'am.
Hi, I'm Eric Carrick. When I keep hearing about opioids abuse, what percentage of it is by illegal drug trade and what is through the medical system? And is it going to be hard to tackle this because of the influence of the pharmaceutical industry, via their donations to politicians?
So the issue of there's three categories, if you will. There's the illicit drug being prescribed licitly, so a doctor is prescribing, but she or he is prescribing 20 pills when 7 would be adequate. And we know there's a New England Journal of Medicine article recently, same type of patient going to the same ER, 2 docs. One doc prescribes more routinely, the other doc less. And because of genetic susceptibility, a certain percentage of those patients prescribed the greater number of pills will become addicted. So that is the legal drug being prescribed in a legal fashion, but perhaps not appropriately. There's the illicit drug, the licit drug, the legal drug being prescribed illegally. There's pill mills. That there will be a doctor who will see a patient every 5 minutes. The patient gives them a check or cash for $250 and walks out with a handful of prescriptions, each one written to the max. And the doc rolls between states, losing their license in Mississippi, getting their license in Louisiana, losing it in Louisiana, going to Oklahoma. That is known well among the medical community. So legal opioids, but prescribed, if you will, illegally. And lastly, there's the illegal drug. There has been a decrease in the prescription of legal medications, but an uptick in the influx of the illegal. How do you know that? Because as we've seen decrease prescription for the legal, the number of deaths from opioids has continued to climb. So it is multifactorial, but it does seem like legal drugs now are illegal drugs are now filling the void from a declining rate of prescriptions. That declining rate of prescriptions is from greater awareness by the dentists, physicians, and other providers out there. Yes, sir.
Yes, Josh Shepard. Regarding this, as a follow-up to this question, regarding that third category of, or rather, the first category, legal drugs that are being overprescribed in a sense, have doctors been amenable to the new CDC guidelines regarding prescriptions of these drugs?
Yeah, probably too amenable, in the sense that I think those are taken as general guidelines, but others are taking them as kind of firmer than that. But my state of Louisiana, for example, the Dental Society came forward to the state legislature and proactively gave medications, I forget which, but maybe 7 days should be the max. And the Medical Society came back and did the same. So, so there has been a response by the dental and medical community to give guidance to our members to get it down. So simple answer, absolutely. Yes, sir.
Good afternoon, Senator. Michael Spira. We know a lot of people become addicted to opioids from surgeries and things of that nature. And is there anything, non-opioids, is there access? How do we get more people access to these non-opioids so they're not becoming addicted from the post-surgery opioids that are being prescribed to them?
Now, part of it is what I described earlier. For some of these very painful conditions, you can do something such as an ultrasound-guided nerve block. And there is this whole kind of sense of non-opioid recovery from surgery that the surgeons are now implementing as well. But part of it is common sense. Now I'm going to speak as a dad. Take my daughter, she gets oral surgery, the doc writes her for 20 of opioid. My daughter weighs 88 pounds. I'm thinking, man, you know, I'm sure it's indicated, but I'm a little nervous about it. So I just put her on arthritis strength Tylenol every 8 hours, and Motrin prescription strength every 6 hours, but I would overlay them, and she never needed it. So part of it is just awareness. You can use Tylenol and a non-steroidal, which have different mechanisms of action, and you can stagger their dosage and use them at higher dose and never have to use an opioid. So part of that, which is the person who is really desiring to stay off of opioids but have significant pain relief, can still do that as well. Maybe one more question. Yes, ma'am. I think they want you to wait for the microphone because we're streaming.
Thank you, Senator. Given your position on help and finance, I had a question. I know that both committees have approved opioid packages. Do you know what the holdup is in there being a package brought to the Senate floor that can be voted on, kind of like what the House has already done? Are there any sticking points that are delaying it or anything?
No, I just think it's probably, I mean, there's a minimum of floor time and a maximum of things to be done. I don't think there's any sticking point per se. I'm never quite the right guy to ask about process, but there is spending bills and appointments that have to be done. But there's a lot of concern about opioids, which is bipartisan, and I do anticipate that. I have a hard out at the bottom of the hour. I thank you very much for your concern about the issue. Thanks for the great questions, and John, thank you for having me.
Thank you, Senator. Join me in thanking the Senator for being here.